All right, let's talk about lichen planus for a minute. Lichen planus is one of the many skin conditions which is characterized by a primary skin lesion. If you look at previous videos, it's characterized by a primary skin lesion, really two skin lesions, but the one that you must commonly see in an not active infection, but an active condition of lichen planus is a plaque, which is one of the many types of primary skin lesions. Let's talk about lichen planus. Now, lichen planus is a skin condition and it is not infectious related. It's not infectious, it's actually non-infectious. It is a non-infectious immunomediated skin reaction, all right, in which the cause is unknown. The only thing really that's written in books or embooks is that the fact that in lichen planus there is an attack by lymphocytes, like for example the Langerhans cells. The lymphocytes, they attack some of the cells in the epidermis, like the keratinocytes, for example. They attack some of the cells in the epidermal layers, the four subtypes of epidermal layer. So the lymphocytes can attack some of the cells or some of the epidermal cells, and this causes inflammation. And with inflammation, this can lead to the development of a primary skin lesion because there's a pathological change in the skin. Now, the etiology why this occurs is unknown. It is completely unknown. But fortunately, this disease is self-limited, and it's not serious. It's a lesion or lichen planus, the skin condition or the skin disease. It's really something that's self-limited. It can resolve itself within 3 to 6 months. But it still requires follow-up with dermatologists because there is some complications, especially with many variants of lichen planus, such as ulcerative types, where they can cause squamous cell carcinoma, or they can cause alopecia, or they can cause loss of nails, for example. So these are complications that might occur, especially with ulcerative type. So you might require still a follow-up with a dermatologist, but overall the prognosis is good because it's a self-limited disease that can resolve itself within 3 to 6 months, regarding to the lesion at hand. So this is the problem with lichen planus, is that there's a inflammation by the lymphocyte. It's attacking its own cells in the epidermis. And with attacking its own site in the epidermis, it can cause inflammation and edema. It can lead to thickening of the epidermis. This can lead to keratosis, increased number of keratinocytes. Could also cause granulocytosis, which is increase in the granular layer. And eventually, this can lead to separation of the epidermis and dermis. The layer between will separate apart, and eventually over time, this can lead to, maybe over time from the outside, development of what is known as a plaque. So now that we finished talking about the etiology of lichen planus, let's talk about the clinical feature of lichen planus. What do we see exactly? So here we have a drawing of a human being, or an attempt at trying to draw a human being. And what we see here is a bunch of lesions characterized by the letter X. X is basically the site of the lesion in lichen planus. And lichen planus is characterized by a raised lesion known as plaques that can be seen throughout the body. It can be seen in the genitalia especially. It can be seen in the inner thighs. It can also be seen in the wrist. It can be seen in other regions, but really some of the 3 most common sites you can see a lichen planus condition is lesions, raised lesions, especially in the wrist, in the trunks, and in the genitalia. And typically these lesions are bilateral. They're symmetrically bilateral. So if you have a lesion on the left wrist or in the right side of the wrist, you might see it on the left side of the wrist as well. And what do these lesions look like? I keep saying plaques. Well, specifically, these lesions are purple in color. If you look at pictures, they're purplish to reddish in color. And these lesions, as we said, are papules. Or not plaques, they could be plaques, but they're mostly papules. Now, if you remember papules are raised lesions, less than 1 centimeter. If they're more than 1 centimeter, they are considered as plaques. So plaques, papules, they're the same thing, with differences in the size. So typically, these purple-colored lesions, they represent the lesion found in lichen planus. They tend to be in the form of 4 P's. 1, they are purple-colored or reddish-colored. Purple-colored, itchy or pruritus, another word. Purple, itchy papules or plaques that are deposited in a bilateral symmetrical manner, especially in the wrists, especially in the inner thighs, and especially in the genitalia region. You can find it in other sites, such as in the mouse, where you have oral lichen planus, which resembles candidiasis, but if you want to think about the most common sites, you can remember by the drawing. And remember, if you see, for example, a primary skin lesion in the wrist, you don't have to necessarily assume this is lichen planus. There are other conditions, like two other conditions, such as contact dermatitis and scabies. So this is two other conditions where you might see a skin lesion, especially around the wrist. But one of them for now in this video is going to be lichen planus. This is why I have S here. S scabies, contact dermatitis, CD, and LB is lichen planus. Now, let's continue with the clinical features. Again, there are purplish, very itchy papules in which the top surface of this papule shows a whitish reticular pattern like this. And this whitish reticular pattern is what is known as what? It is known as Wickham stria. This is a very characteristic feature of basically lichen planus. You basically have purplish, very itchy papules or plaques in which the very top surface of these papules or plaques have a reticular white pattern, like a network line, like these. And these are called Wickham stria, and these are characteristic of lichen planus. Another one is that their surface is flat. You might see in some books or some handbooks they say that they have flat topping. Flat topping does not mean that the lesion is flat. No, the lesion is raised, but the surface of it, like for example here, the surface is flat, and it shows the Wickham stria, as we see right here. Along with that, it has irregular borders, okay? Like in this lesion right here. You have irregular borders with a flat topping, and in this top of the surface of this plaque contains the reticular white pattern known as Wickham stria. And if I were to take a biopsy of this, I will see a sawtooth appearance. Basically, what sawtooth appearance means when I take a biopsy and look under the microscope is what I mentioned before in the video. It means that there's epidermal thickening as a result of inflammation, there's granulocytosis, keratocytosis, a result of lymphocytic inflammation in the epidermal layer. So that's another diagnostic feature when you take biopsy. So lichen planus, when you look at pictures, the diagnosis is a clinical diagnosis plus a punch biopsy, where you look at the histopathology, where you will see what is known as a sawtooth appearance, okay? Besides that, there are other things that you might see besides the papules, or besides the plaques in lichen planus. You might see a phenomenon known as Koebner's phenomenon, and this is not exclusive to lichen planus. You might see this in psoriasis. This basically means whenever you have a trauma on this side, for example, this side, when you have a trauma on this side, it will lead to induction of the lesion of lichen planus. So I might have a lesion of the lichen planus in my left wrist if I have trauma in this region. So this phenomenon is known as Koebner's phenomenon. Koebner's phenomenon. You might see this in psoriasis, so not exactly specific. But something that's might be more specific to lichen planus is following the healing. We said before, all this involves lymphocytic inflammation. Let's say the inflammation resolves itself. Let's say the inflammation resolves itself. Then in that case, these plaques, these papules, they will not stay as papules. They will heal in the form of hyperpigmented macules. So they will convert from a raised lesion to a flat lesion. So some of these lesions may become flat and then become hyperpigmented. And they might see, let's say when the lesion resolves itself, these plaques and papules, when they resolve itself following inflammation, they might appear as hyperpigmented macules. So that might be a characteristic feature of lichen planus once the acute inflammation resolves itself. So initially, it may begin as papules. Papules may progress to plaques, and then eventually a papule and a plaque, once the inflammation subsides, it can appear in the form of hyperpigmented macules, multiple hyperpigmented macules, okay? So we finished with the clinical features of a lichen planus, especially what is the primary skin lesion here. There can be more than one. What are the sites that can be seen here, and how to diagnose it. It's clinical and via biopsy. And of course, there is many differential diagnoses for lichen planus. For example, in lichen planus, it could be lichenoid drug reaction. Lichenoid drug reaction or lichenoid drug reaction basically means you have a drug eruption that might induce lichen planus. So you can think of it, lichenoid drug reaction, as an acquired cause of lichen planus. You might have the same features, but the difference is that there is no Wickham stria. You will not see this reticular white pattern, especially if you look at pictures. You will not see this reticular white pattern, Wickham stria, in a drug reaction. That is the key difference. The same goes for oral candidiasis. Oral candidiasis, especially if you have oral lichen planus, if you have a plaque with this Wickham stria, you might think this is oral candidiasis. So how do I differentiate oral candidiasis from oral lichen planus? I do scrapping. If I am able to scrap the plaques in my mouth of a child, then this is candidiasis. But in the case of oral lichen planus, you're not able to scrap it off, but you can in candidiasis. So this is the key difference. Other causes could be discoid lupus, a specific type of SLE that might present with the same thing. Again, you might see with other systemic features that this might be a case of SLE and not lichen planus. So these are differential diagnoses you can think of whenever you have lichen planus as your most likely differential diagnosis. Not just lichen planus, also differential diagnosis to exclude as well, which you can exclude by clinical diagnosis and as well as biopsy, and as well as we mentioned before, the scrapping and all that. Okay. And as we said, the complications, yeah, it's not serious. There's many subtypes of lichen planus, and one of them is ulcerative, especially it might induce squamous cell carcinoma. So typically, it's self-limited. The prognosis is good, but you still require a follow-up with dermatologists for assurance. And now that we talk about assurance, we could talk about the treatment. Treatment is reassurance. It's not necessarily serious. However, we can treat lichen planus. It does not necessarily mean we have to leave it alone, especially if you have primary skin lesions such as in lichen planus with the plaques or the papules. Here in this case, you include as a first-line treatment a dose of potent topical steroids. You can give this patient, in most cases, potent topical steroids to the lesions, and it can resolve itself over time. But if you have a severe case, you can give this patient systemic steroids if necessary, or expose the skin to ultraviolet radiation. Whatever you want. But the first line treatment they might start with is potent topical steroids, especially for the skin lesions, as well as reassurance and follow-up. Okay? That's pretty much it for the lichen planus. This is, as we said, a skin-mediated reaction, which is non-infectious, immune-mediated skin reaction or skin disease with an unknown etiology. Again, the cause is unknown. It could be associated with alopecia, ulcerative colitis, certain drugs like antibiotics, streptomycin, could be hepatitis B or C infection, or associated with bone marrow transplant, but the cause exactly is unknown. Okay? That's pretty much it for the video, and I'll see you to the next one.